The mass adoption of low-dose CT screening has triggered a sharp surge in the detection of incidental pulmonary nodules. The standard clinical reflex upon finding one of these rounded opacities is to heavily associate it with the patient's smoking history and to calculate the potential risk of lung cancer. These 3 CT scans show the distinct morphological phenotypes of pulmonary nodules that radiologists evaluate to determine that risk. Panel A displays a solid nodule, an opacity dense enough to entirely obscure the underlying lung parenchyma. Panels B and C display part solid and ground glass morphologies. These hazy, semi-transparent opacities traditionally generate higher oncologic concern and demand rigorous follow-up. The sheer volume and morphological diversity of these incidental findings is creating a systemic bottleneck in clinical workflows. Separating benign anomalies from true oncologic threats requires a massive epidemiological baseline. The Swedish CardioPulmonary bioImage study, or SCAPIS, provides exactly that baseline. SCAPIS is a cross-sectional population-based study analyzing comprehensive health data and imaging from randomly selected middle-aged individuals to map precise cardiovascular and pulmonary norms. If nodules are primarily smoking-related, analyzing a population with low occupational exposure and varying smoking habits should reveal a steep drop-off in prevalence among non-smokers. This bar chart shows the actual prevalence of pulmonary nodules across the entire cohort. The baseline reality is stark. Roughly 34% of the entire analyzed population harbors at least one pulmonary nodule. Breaking down this prevalence by smoking history yields a surprising result. Among participants who have never smoked, 32.5% present with solid nodules. For those who formerly smoked, the prevalence is 34.5%. For those who currently smoke, it is 37.9%. The trend line across these groups is remarkably flat. Nearly a third of individuals who have never touched a cigarette exhibit nodules on a routine low-dose CT scan. This flat prevalence curve proves that smoking alone cannot explain the vast majority of pulmonary nodules. To understand what actually drives their formation, we must examine the specific health markers of non-smokers. This flowchart details the statistical power of the dataset, tracking the 30,154 enrolled participants down to a final analyzed cohort of 29,574 individuals with completed chest CTs. This group represents a largely healthy, well-educated, middle-aged population spanning 50 to 64 years old. Among participants with nodules, the breakdown reveals a dominance of solid phenotypes, totaling 10,018. A volumetric breakdown shows the vast majority, over 8,200, are smaller than 100 cubic millimeters. Contrast this with the rarity of high-risk subsolid types, only 199 part solid and 430 ground glass nodules. Because high-risk subsolid nodules are statistically rare, epidemiological focus must shift to understanding what drives the presence of those 10,000 solid nodules. The baseline normal for a middle-aged lung includes a high likelihood of harboring tiny, solid nodules. Therefore, the mere presence of a nodule is a poor standalone metric for triaging patient risk. To identify the actual variables driving solid nodule formation, the researchers utilized robust Poisson regression analysis. Poisson regression is a statistical method to model the relationship between a binary outcome, like the presence of a nodule, and multiple independent risk factors. These forest plots map prevalence ratios. We focus on panel B, tracking mid-sized solid nodules. The highest driver is general lung disease at 2.32. Next are structural findings, bronchiectasis and reticulation. Notice the comparatively lower influence of current smoking, sitting further down at 1.38. Reticulation refers to a network of intersecting linear opacities on a CT scan, indicating scarring, while bronchiectasis is a permanent widening and damage of airways. Both serve as distinct markers of architectural distortion and focal inflammation. In a general middle-aged population, a mid-sized solid nodule is statistically more likely to be a byproduct of structural lung damage than a direct isolated result of smoking. To definitively separate these distinct etiologies, the data must be stratified directly by smoking history for nodules larger than 100 cubic millimeters. This plot isolates the never-smoked cohort to reveal baseline drivers without the confounding variable of tobacco use. The dominant risk factors in this non-smoking group are reticulation, lung disease, and bronchiectasis. Notice the explicit absence of COPD or severe emphysema as statistically significant drivers in the never-smoked cohort. Switching focus to the currently smoked cohort reveals a critical shift. General lung disease and reticulation remain top universal drivers, even with active smoking habits. However, emphysema and COPD emerge as highly significant drivers, appearing only in the smoker cohort. Active emphysema and current airflow limitations heavily compound the baseline structural risks that are already present in the lung. The etiology forms a clear dichotomy. A nodule in a never smoker is driven by structural and inflammatory history, while a nodule in a smoker is a complex mix of baseline structural damage compounded by active emphysematous destruction. By stratifying the data, SCAPIS demonstrates that structural parenchymal disease is the universal foundation of nodule formation. Smoking acts as an overlapping, compounding etiological pathway, not an exclusive one. While solid nodules dominate the data, subsolid nodules, part solid and ground glass opacities, carry higher clinical stakes despite their rarity in this cohort. This chart analyzes regression data for ground glass opacities. They show an expected association with current smoking and high occupational exposure. But look at the counterintuitive anomaly at the bottom. Obesity appears to have a protective effect, showing a prevalence ratio well below 1. Increased body fat does not biologically protect against nodule formation. Rather, increased body habitus reduces the physical sensitivity of low-dose CT scans in detecting faint ground glass opacities, revealing a critical technological blind spot in mass screening protocols. Translating this epidemiological data back to the daily reality of the clinic requires applying the Fleischner Society guidelines. The Fleischner Society guidelines are the international standard medical recommendations for managing and tracking incidentally detected pulmonary nodules. The mass screening data generates a tremendous amount of baseline noise. Roughly 34% of the population possesses a nodule, flooding clinics with incidental findings. But out of the nearly 30,000 analyzed participants, what percentage actually required clinical follow-up? This funnel chart shows the final actionable reality. When filtered through strict clinical guidelines, only 6.1% of the cohort possessed a concerning incidental nodule. This actionable tier consists solely of nodules larger than 5 millimeters in volume or specific subsolid opacities requiring tracked follow-up pathways. The vast majority of detected nodules require zero intervention. The SCAPIS data provides a new clinical heuristic. When a clinician finds a small solid nodule in a non-smoker, the immediate reflex should be to review the lung parenchyma for reticulation or bronchiectasis, rather than simply calculating a lung cancer risk score. Failing to separate benign, structurally driven incidentalomas from true premalignant findings leads directly to systemic overinvestigation, unnecessary radiation exposure, and severe anxiety for the patient. The data demands a recalibration of our risk models. We must stop viewing all pulmonary nodules as exclusively smoking-related threats and recognize them as highly common markers of a lung's unique structural history.